So I will be talking today on behalf of the entire rehab kind of spectrum, all the disciplines of physical, occupational, and speech therapy. Looking at some updates and research, some findings that we might um, see in clinic with our evaluations and some strategies throughout. And you can put questions in the chat, and we'll have some time during the expert panel later today, so you can submit for that as well. So here is a breakdown of what I'm going to talk about today. So first, I'll go over the rehab care in Huntington's disease, and for anybody who is unfamiliar with what PT, OT, and speech therapy can do for you, I've broken that down as well. Then I'll go over physical therapy, then occupational therapy, and since I'm a speech language pathologist, we'll go over some of the swallowing and speech and cognition sort of spectrum of things. And I'll focus a little bit more on that just since that's what I'm most familiar with. So types of rehab, we have physical therapy, which can look at balance, gait, fall prevention, getting an exercise program going. And then they can provide some adaptive equipment as needed to help try and reduce falls and help with mobility. Occupational therapy, no, they are not related to getting you working. They are getting you ready for your ADLs, your activities of daily living, such as personal hygiene, dressing, feeding, riding, home safety, and they too can give some adaptive equipment for feeding, for riding, for whatever it is that you want to do. If you have a hobby that you really enjoy, art or something like that, they can always figure out some equipment that can help you. And then my area of speech language pathology, we look at speech, swallowing, cognition, language, such as how you express yourself, coming up with the words you want to use, and then comprehension, your understanding of language. So we'll hit all those areas today. Rehab care in HD, we recommend baseline evaluation. So once someone gets the diagnosis of manifest HD or even pre-manifest HD, it's not a bad idea to get baseline evaluation. So we have something to compare to. And then doing follow-up evaluations every 6 to 12 months. As the disease changes, we want to be able to adapt our recommendations and what we are giving you. So those reevaluations are really, really important. And therapy should be individualized and functional due to the complex and variable nature of HD. So everyone is different. Everyone has different hobbies that they like to do, family dynamics, home settings. And so we want to be able to make it really practical. What are the things you're having a hard time with and help you with that? And then it is always helpful if you have a therapist that has a background in neuro, particularly PT can have a neuro PT versus an orthopedic PT. So we really need to make sure that we're finding specialists who understand the diagnosis. And on each beginning slide for each discipline, I have some resources in case there's any therapists on today, or you want to share it with therapists you're working with. And as HD progresses, therapy will evolve. So we'll go from exercises and strategies to more compensatory nature and more working with the care partners, rather than trying to get you exercising and safe swallowing and things like that. We have to adapt as it progresses. And so how can we go about doing that? And I'll hit some points on each discipline slides as well. So I'll start off with physical therapy. As I mentioned previously, I have some research or guidelines that therapists can use, or those who just want to see what physical therapy can do for you. Some references there. So balance and gait changes in Huntington's disease. Ultimately, the changes are multifactorial. We have impaired static and dynamic balance, increased postural sway. There's a higher degree of gait variability compared to other neurological disorders and healthy controls. Shorter stride length. And then we also know cognition, the severity of the chorea, if there's presence of dystonia or apraxia, those can further negatively impact gait and balance. And there has been research to show that dual tasking, particularly with a cognitive task, tends to be harder for those with Huntington's disease. So making sure you are integrating those things, that could be an example of walking and coming up with words you want to use, or counting backwards and walking. So that is more of a dual cognitive task. Also, attention to task and divided attention is more difficult in Huntington's, and that too can lead to falls if someone isn't paying attention to the environment or easily distracted by something. And then impulsivity. So, and a great example is getting up and going before getting balance and having a fall. PT interventions in Huntington's disease. Aerobic exercise at a moderate intensity 5 times a week for 30 minutes, or ultimately 150 minutes per week. So this is something that is really stressed early on, getting an exercise routine going. We know how important it is for the brain to exercise. So this is something that they're going to prioritize early on, and something that once you get into the routine, we hope that you keep up with. And this can improve fitness and stabilize or improve motor function. And it can also be combined with resistance training per the research, as well as one-on-one gait training. So this will improve spatial temporal measures of gait, such as how fast someone walks and the length of each step. There's also task-specific gait training, fall prevention. They can help train patients and care partners how to safely transfer and how to best transfer. We don't want care partners hurting their back, or both the patient and the care partner going down together. So how to safely transfer, and then getting up off the floor. So if there is a fall, what can you do? How can you best get up off the floor, without having to call 911? Adaptive equipment such as walkers, positioning devices, and seating changes, as well as care partner strategies and training. So ultimately, as HD progresses, PT interventions move from exercise early on to maintaining independence and reducing falls and moderate disease severity. And then end stages is more mobility. How can someone get around? How can family get you around safely? Now I will focus on occupational therapy. So what is occupational therapy? It is to maintain or improve your ability to perform activities of daily living. And I have some examples here of activities of daily living. So ultimately, they're finding ways for you to be able to continue to live your life and do the things that are necessary. So housework, work, if someone is still working, self-care, like hygiene and bathing and dressing, and making sure these are safe. So we know self-care in Huntington's disease can be impacted. So 71% of persons with HD endorse difficulty doing self-care, and a third of those stressed dressing, brushing their teeth, and shaving are the most challenging. And overall, they also found a reduced satisfaction with their ability to complete self-care, which then led to reduced motivation to do the tasks and then no longer doing the tasks. So we know that daily routines and weekly schedules will ensure that self-care is attempted. So making sure brushing their teeth is twice a day, making sure maybe shaving is once a week, or taking a shower and cleaning the hair is twice a week. So put it on a weekly schedule or a daily schedule, and it's much more likely to be completed. And starting this earlier on will help keep it up through the rest of the disease changes. So some examples of some self-care difficulties are impaired fine motor skills and coordination, which impacts dressing. So an example is avoiding clothing with buttons. Those can be hard to do, some of the fine motor. And then avoiding shoes that tie or flip-flops. So you want supportive slip-on shoes, and I have two examples that our occupational therapist, Lisa, gave to me. So these just have more of the elastic ties without having to actually tie your shoes, but they are supportive and aren't going to get in the way of walking like flip-flops might. And then impaired motor control impacts the ability to shave and brush teeth. So using battery electronic toothbrushes and razors to provide increased safety and independent success. So obviously, we want to make sure these things continue to happen, but in a safe manner. And I skipped one, loose-fitting clothing with elastic bands. So instead of those buttons and things like that, much quicker to get down for using the bathroom and pulling on. So now I will jump ahead to speech language pathology. So this is my area, so I'll talk a little bit more about it. So speech in Huntington's disease can lead to dysarthria, and the speech changes and speech intelligibility or someone's ability to understand you worsens as Huntington's progresses. The most common form of dysarthria, which is a speech change, is hyperkinetic due to the extra movements, the chorea, but you can also have different features of other dysarthria forms, such as hypokinetic dysarthria, or even like apraxia of speech, some difficulty planning the speech sounds and how to produce it. And across the board, it is variable. And so not one person with HD is necessarily the same. And so making sure the speech therapist is adapting to that. What is the person's difficulty communicating? Is it volume? Is it clarity? And trying to help with that. We also know that cognition, someone's motor abilities, mood, and apathy also can impact speech and language. So having to make sure we consider those things when treating the patient. Some of the speech changes may be imprecision, variable volume or rate. Some studies showed faster rate, some studies showed slower rate of speech. Reduced respiratory coordination for speech, so maybe speaking on the inhale or not taking in a deep breath for speaking or having to pause frequently to continue to speak through a sentence. Hoarse, harsh, or strained voice. Abnormal breath pauses, so not necessarily taking those breaths at typical word boundaries or sentence boundaries like punctuation marks. They might be more in the middle of a word or somewhere randomly in a sentence. Prolonged pauses and abnormal prosody. So we'll hear some variability in the tone of the sentence. Dysphagia in HD. We know that there's an increasing prevalence of pharyngeal dysphagia as Huntington's disease progresses, and this impacts safety. So this graph here, we have the prevalence of dysphagia, with the dark blue being early stage Huntington's, the teal being moderate stage Huntington's, and the orange being late stage Huntington's. We have prevalence of dysphagia on the x-axis, and then the percentage of the participants in that study that had it. So we can see that as the disease progresses, the presence of pharyngeal dysphagia increases. And further, the study found that the presence of silent aspiration, so things going down the wrong way without someone having a cough response, also increases as the disease progresses. And so this is something really to consider, is that we know someone might not be showing signs of swallowing difficulties by coughing or clearing their throat. And so that's where doing an instrumental swallowing evaluation, like an X-ray video, we call that a modified barium swallow study, or even a flexible endoscopic evaluation of swallowing, a FEES, which is what they did in this study, can help assess the pharyngeal stage of the swallow. In addition, we know that movements of the mouth, the face, even the body can impact the oral phase. So you get something in your mouth and the tongue might be moving in an abnormal way, pushing the food out. Maybe we're having difficulty even being able to get food in, chewing. You might have food spilling out your mouth. So looking at both the oral and the pharyngeal stages are important for speech pathologists to evaluate. Some basic swallowing strategies I recommend: eating and drinking, making sure you're upright, not reclined or lying in bed. Single smaller sips and bites of food. So this I will touch on a little bit later on, but there are some flow control cups or straws that we can use to limit the size that someone might have for a drink. Smaller utensils, even if there's multiple bites of food, the smaller utensils only get so much in the mouth. And then smaller plates or portions presented at a time so that all of it doesn't quickly go in the mouth and we have a choking or safety issue. And then really limiting distractions in the eating environment. If you're going out to a restaurant, for example, the person with Huntington should face more of the quieter side, maybe the wall if you get a corner booth, rather than looking out at the crowd, people watching TVs. Swallowing is a very coordinated task, but slight issues with coordination timing can really impact the swallow. And then managing reflux if that is present. And oral care. This is something I cannot stress enough, like we talked about with occupational therapy, getting it into part of the self-care routine. Those with HD compared to controls in a study found significantly more decayed teeth and plaque. So this is something that, research supports, but we also know from a swallowing perspective, if you reduce the bacteria in your mouth, even if things occasionally go down the wrong way and are aspirated, going down into the airway, less bacteria is attached to it. So this is something that we always stress from a swallowing perspective. It takes 1 to 2 minutes, in the morning and in the evening, but it can make a huge difference in terms of swallowing and overall health. And then a higher motor impairment and lower functional status of the patients with HD lead to worsening dental status. So we can kind of say, okay, well, as the disease progresses, we're going to have worsening dental status. So still have those regular dental visits, probably every 6 months if you can afford it, maybe even every 3 months, but really trying to make sure that this is continued on, even if a care partner is having to help out with it. And then cognitive changes in HD, increasing prevalence of cognitive impairments as duration of HD increases. So here in the dark blue, we have mild cognitive impairment, or MCI. In the teal, we have dementia, and in the orange, we have no cognitive impairment identified. And so this one is only from 19 patients with HD at the onset of motor symptoms, and you can see a significant portion already had a mild cognitive impairment. So early on, we see those cognitive changes. And then after about 5 years of motor symptoms, we see that that larger portion of those with MCI have now turned into dementia. So the cognitive changes also impact everything across the board, but really trying to get some therapy earlier on for those cognitive changes to try and slow the progression of it. And then these changes might include executive function deficits, so difficulties with planning, attention, working memory, processing speed, problem solving, language deficits, and then memory. So here are just some examples of things you can do to stimulate your brain and get some daily brain exercises in. So just like PT recommends aerobic exercise, we want to make sure we're also getting some brain exercise in. The one on the top left should say Brain HQ. It kind of got cut off there. But that is one that our team recommends. But really, it's anything that you would do. So aerobic exercise, brain exercises, whatever interests you, but gets you to that goal of getting that daily exercise in. And then some barriers in Huntington's disease are reduced insight as the disease progresses, apathy and impulsivity. And apathy and impulsivity can be present even before the Huntington's disease has manifest. So apathy is lack of motivation, and this is present in up to 70% of those with Huntington's disease, and it worsens as the disease progresses. So this is something that PT/OT speech is constantly having to consider. We got to get that motivation. The way you fight apathy is put it into a routine. So that's why we talk so much about routines and exercise routine, self-care routine, brain exercise routine. And then impulsivity is reduced problem solving and decision making, leading to doing things quickly or impulsively. And up to 45% of those with Huntington's disease scored above the clinical cutoff for impulsivity. And more than 90% of caregivers reported at least one risky behavior. Some examples: impulse or compulsive behaviors, adverse social behaviors, or reckless driving, which will lead into the next talk, which is about the safe driving program. And impulsivity during eating and drinking can lead to large bites or large sips, or eating and drinking too quickly. So here are two examples of equipment that you can use instead of having to tell the person with Huntington's disease, slow down, one bite, one bite. External strategies are going to help. So the safe straw limits to about 6.2 milliliters, and it could be used for thin or thick liquids. And then the Prevail cup, they have one for 5 cc amounts and 10 cc amounts. So depending upon what the speech therapist can recommend, but it limits to that amount. And you can actually take the handles off of those cups, make it look less like a sippy cup if needed, but with the Korea can be really helpful. And then insight, we have to consider this as well. It diminishes as HD progresses. So someone with Huntington's disease may not recognize that something is an issue. They may say everything is okay, their health is excellent. And so really having to question the care partner, what are the things we can help you with as the disease progresses? So this is something that even if you're coming into the speech PT or OT session and the patient doesn't recognize the issue, so you're like, oh, this isn't going to be helpful, we can work with the family to make sure that we can try and keep them as safe and active as possible, even towards end stages. So in summary, we know that every kind of area that I talked about today worsens as HD progresses, and we know that currently there aren't medications necessarily that help with all these areas, and so that's why PT, OT, and speech are really important. We recommend baseline evaluations and reevaluations every 6 to 12 months. We highly recommend aerobic exercise up to 150 minutes a week, so 5 times a day for 30 minutes in the moderate heart rate range. Routines for self-care, and then I'm promoting oral care as well as cognitive exercises. And we really have to consider the cognition, apathy, impulsivity, mood, and then that reduced insight in persons with Huntington's disease while we're trying to treat all of these areas. So here are my references. And I just want to say thank you for having me talk today and talk about the importance of PT, OT, and speech in rehab care.